So our format's going to be a little different right now. What we'll have is the speakers will come forward and speak for about 5-6 minutes. And then after that, there will be some questions, sort of do it as a bit of an interview, news interview, and then questions from the audience. We are, as you know, under some time constraints. So when we get to the questions from the audience, I certainly will try to keep the questions, please, to 1 minute, and the answers to a max of 2 minutes, so that way we can engage more people. All right, so we'll start off, please, with Doris.
Thank you. Thank you very much for having me today here. It's always a pleasure to be with Ontario and the Canadian Health Coalition on the same forums. My gosh, the issues of P3 are serious, and I think that René wrote the papers on that about 10 years ago, and you can see the analysis and still continues. And the latest frontier now is, in addition to P3s and in addition to private for-profit clinics, medical tourism, which interestingly, most people in this room, including Steve, with whom I spoke just before he left, are completely unaware of. And that's the tragic piece of it. Let me put it in simple words. Medical tourism, it's not when someone goes abroad and gets the care. Yes, that is, but I don't care about that. It doesn't use our taxpayers' dollars if they pay out of their own pocket. Medical tourism is not if a person comes to Canada to visit, breaks a leg, and needs a cast. That's not medical tourism. And medical tourism also was not the initiative that René supported very heavily and didn't come to fruition, which was to bring the kids from Gaza for treatment. That is humanitarian care. Medical tourism is when hospitals like University Health Network go to their website, Sunnybrook go to their website, and others which have not dared to put that on their website yet, are soliciting patients from abroad for a fee. In 5 minutes is not much that I can give you about all the research we have done, so simply let me tell you this. Go to our website, www.rnao.ca, www.rnao.ca. You will see every single piece of analysis and research that has been there, except for the latest, which is the Freedom of Information that we issued about 3 weeks ago, and that I'm discussing tomorrow with the Minister Hoskins. Medical tourism is simply wrong for the reason of all the core challenges that this country has had, whether it is the Shaoli and Ziliotis in Quebec, where a patient from Canada thought he can get care for pay and be ahead of the line, or Brian Day in B.C., where he has a whole clinic that is based on that. The moment that we have patients from abroad solicited by our hospitals, approved by our government, and they get care ahead of the line because they can pay, we have no leg to stand in court with the Canadian patient, and nor should we have a leg to stand. Because if a patient from abroad can get care for pay and be ahead of the line, so should anybody else, and that's the end of Medicare. So when the media meets with me, and they do often, not only on Ebola, but on this, and they ask me why it's so problematic, the answer is very simple. If a patient from abroad can get care for pay, so can our patients, and that is the end of Medicare. So I urge you all to become fully aware, because while all these other aspects that we are discussing are of tremendous import to Medicare, we may be missing the boat by not putting pressure against medical tourism. There is an action alert in our website. There is over 5,000 people that have written to the Premier and to the Minister. We are this close to them saying that it's prohibited, and you will see more. We have a press conference planned for October 29 with a coalition that we form of healthcare providers, and we will be speaking, unless they stop it before, on against medical tourism. And if that doesn't work, we are going to take government and employers to court. So please do go to the website and put the pressure and ask their families and friends. If you don't, do not be surprised that years from now, you actually will not get the care unless you have money to pay. It's as simple as that to me. So please go to the website. Thank you, and I will answer questions.
Thank you very much. Our next speaker is Terry.
Thanks. It's really great to be here and to hear all this amazing information and what everybody's doing and interested in. So we've already heard a lot about Brian Day and the court case, so I don't have to get into a lot of details about exactly what the threat is and what's happening over there. You know, the overbilling and the double billing that Canby Clinic is doing is like, it's really hard to fathom, and how it's affecting patients. You know, so Sean had mentioned about that in 1 month it was, you know, $500,000. So we were thinking, so that's 2 clinics. So it's Canby Clinic, and he also has a partnership with the Specialist Referral Clinic. So that was 2 clinics in 1 month. There are at least 25 other private clinics that do the same kind of surgeries that Day does in BC alone. So we were looking over a 5-year period. We're thinking, okay, you know, that was like an average, because it wasn't a straight 30 days. So it's not like, oh, that was a fluke month, right? It was over like three periods over like 1.5 years or something. So, you know, it's happening a lot. And it's also interesting that a lot of these extra user fees are labeled in their accounting system as pediatrics. So why an orthopedic, you know, surgery clinic would have, you know, pediatrics charges is like all very, very interesting. But, so we figured over a 5-year period, they brought in almost $34 million on overcharging patients. And so I can't imagine if you add up all the other clinics in BC, what type of money is changing hands. So we became interveners. As Sean said, we wanted to be a part of the process. We were at the beginning really worried that the government wouldn't put up a good case. We don't know what the government thought about it, but lawyers like to win. So their lawyers were putting up a really good case, and we were really pleased. We were also able, by being part of the process, to work with the lawyers, intervene where we could, and also it gave us, as interveners in the case, legitimacy in the campaign work. So it wasn't just like, oh, those people over there who are, you know, always squawking and making noise and being negative. It's the fact that we were part of the process of what was going on. And that was really helpful, because we realized this isn't just a legal case, but it's a public case. Like, we need a public campaign. And we talked yesterday about the need for public awareness. We need people to stand up. And we also talked about how hard it is to get the word out. And, you know, Stephen had mentioned that the media in BC is even a harder nut to crack than it is in Ontario, and it's like incredibly frustrating because like the Vancouver Sun keeps putting the same story in the paper about Brian Day and how basically he's the champion of healthcare in Canada, and no matter what we do, we can't like refute that in the papers. So our campaign work, we've really focused a lot around getting public awareness out, and for a couple of reasons. One, as our lawyers said, judges are people too. They read the papers, they hear what's going on, they get the lay of the land. But also, we wanted to make sure the government heard that people cared about this case a lot and that they couldn't backslide, or they had to stand up strongly for public health care. And you know, we've been working across the province with all of our allies. We've been working nationally. The Ontario Health Coalition and the Canadian Health Coalition have been like incredibly supportive, as well as the other health coalitions across the country, and so that we can get the word out that this is a huge danger. Some of the campaigns that we have done, we've done town halls and presentations. We've been building our email lists. We've been trying to spread the word through social media. We've created a social media amplification team where we tell two friends, they tell two friends, and so on and so on. We have a letter to the editor campaign that we did across the country, which was really great. And our latest one was to email the BC government so that to let them know that now that they're negotiating with Day behind closed doors, that it's I saw you in the corner of my eye, that now that he's negotiating, that there's expectations. And we have so far sent almost 1,500 emails to Christy Clark and the Minister of Health, Terry Lake. For some reason, they haven't responded to 1,500, people asking them to take the case. Can I just a couple more things? Do I have time? No? So I was going to tell you things I've learned, but I'll have to tell you later. Okay? So thank you.
It'll come up in one of the questions, don't worry. All right, Natalie?
We've had to be a little ruthless here, I think, today. Blood on the floor at the Health Coalition. So, in 2008, we did a major report on private clinics across the country. We phoned all the private clinics, and we actually just redid it again this summer, and we asked them, how many doctors do you have? Do you charge money? Like, can I buy my way to the front of the line? Can I get an MRI? I don't really have anything wrong. I just want to see what's inside, that kind of thing. And what we found was the vast majority of them, not a few, but the vast majority of them bill OHIP. They bill WCD or WSIB in Ontario as well, and they bill patients on top. So they bill every available source. This is how they maximize their profit, and that is the business model, because really a private clinic cannot make it without the public subsidy. So they can't make it without billing OHIP, so they need to have the OHIP services transferred to them, cut out of local hospitals and transferred to them. But they also want to make more money than that, and so they avail themselves of these other billing avenues. And when you look at the prices, they're shocking. So they're not, people don't, we've grown up with Medicare, we don't really have a sense of the price of things, and you know how conservatives are always saying, oh, we should get bills for our healthcare, and people would be more reticent to use, as if people are sitting in droves in emergency departments because they have nothing better to do, using up healthcare dollars. But people really don't know how much they cost. So an MRI in a private clinic, anyone have a sense?
$900.
That's right, $900. It can be $1,000. It can be up to $2,000 or $3,000. The cheapest clinics in the country will be around $800. Anyone know how much it costs in our public hospitals?
$242.
Great. You're ruining my speech. That's right. It's $250 in the public system. What about cataracts in the public system? Anyone know how much we're paying docs to do cataracts? $550 around. Do you know how much it costs in a private cataract clinic?
No.
That's right. In some clinics it's $1,200. In some clinics they'll charge you $100 for an extra, totally medically unnecessary, bogus junk eye exam that they just tell people they need. They might charge you another $200 for another test. They have all these names for these tests. They vary between clinics. They'll tell you that you need, that you can buy an enhanced lens or a better lens. All the language is geared towards manipulating patients to buy this stuff. In fact, some of the clinics we called said, well, you could get it the old way under OHIP, or you can get the better tests, you know, that give you enhanced, you know, more accurate measurements and so on. Well, who's not going to want the accurate measurement of their eyeball done before somebody takes a, you know, a laser to it? I mean, seriously. And these are doctors telling you this. And so the government in Ontario has said, well, it's okay as long as it's optional. So a man was telling me that he went to a colonoscopy clinic in South Ajax just a little while ago, and he was told that there'd be an administrative fee there. I think it was either $50 or $200, I can't remember. But anyway, it was an administrative fee. He said, well, I thought colonoscopy was covered under OHIP, and they said, oh yes, but this fee is necessary. And so he paid it. And then he came to our office and said, really, you have to pay $50 for colonoscopies now? And we said, no, that's unlawful. The clinic claims because they have a sign up in the waiting room that says that there are optional fees and lists what they are, that they've covered that off. But of course they're telling patients that they have to pay it, and patients are believing them. And this is happening all over the place. So the violations sort of run from the flagrant, you know, to the manipulative, you know, selling up and extra billing. And so we now have sort of three major threats in the new assault on public Medicare. One is the transfer of ownership of public and non-profit healthcare to private and for-profit clinics, and ownership in general, in home care, long-term care, hospitals. The other is two-tier healthcare, including medical tourism that Doris is talking about, the private clinics, and the way in which they're eroding the equity and fairness principles of Medicare and the Canada Health Act's prohibition on extra billing. And the third is the way in which healthcare is being restructured to shrink the scope of public healthcare, to push patients out from under the Canada Health Act to so-called community care, which is no longer community care. It's owned by chain companies that have no basis in the community, and in which the modalities of care are different, in which the real motivation is about making as much money as possible. And we need to challenge those things.
Our next speaker is Adrienne.
Okay, so a little bit different. I've been asked to speak sort of on the federal government and national issues. So it's a couple, I'll go through a couple of topics in 5 minutes. Here we go. So first of all, and I sort of talked about some of this yesterday, so those of you who were here know a little bit about what I'll be discussing. Certainly the health accord. So the health accord should be a meeting between the Prime Minister and the Premiers. It sets national standards, but it also sets funding. The problem is that, of course, the Harper government in 2011 dictated what the funding was going to be until 2024. And that is that currently we have a Canada Health Transfer that escalates at 6% a year. It means that the federal government contributes roughly 20% of funding for healthcare across the country. They've changed that. They're now tying it to GDP, meaning that by 2024 they'll contribute 18%. Regardless of the fact that when we started Medicare in this country, we had agreed to a 50-50 cost-sharing program between the federal government and the provinces and territories. So we're seeing the federal government play a much smaller role. What does that mean for privatization? Well, it certainly means that Ontario is going to lose $14 billion in the next 10 years. And so they're under a budget where they're looking for any way that they can cut costs. And so we're seeing privatization. We're seeing that actually across the country. So we heard from our sister yesterday in Nova Scotia talk about the attack on workers that are happening there. In addition to what she was speaking about, the Nova Scotia government, for the first time in its history, passed essential services legislation just last year. We've also heard from Leo Glavine, their health minister, that maybe we should start thinking about healthcare like banks, where you have to pass this merits test and this to show that to prove that you've taken care of yourself before you can access the public health care system. I know, right? In New Brunswick, when we had talked to the minister there, and we told them, you're going to be facing huge cuts because of a loss through the Canada Health Transfer, what are you going to do? He said, well, New Brunswick patients won't even feel it. We've already started to address that. And they cut 400 nursing jobs and privatized and contracted out their cleaning services. In Saskatchewan, we've just heard Premier Brad Wall recently say that he wants to introduce private MRI clinics. Now in 2008, he said that would be unethical, but now he seems to think that this is a legitimate thing to do. And so he started a Twitter campaign, and we're asking people to get involved, start tweeting Premier Brad Wall and tell him why private MRIs are not the solution to healthcare savings in this country. And BC, we've heard lots about the Dr. Day Clinic. The federal government has a role. They have that Canada Health Transfer. It's their responsibility to withhold money from the provinces and territories. They've chosen not to do that. They've turned a blind eye, despite, as we heard from Sean Mehra earlier today, that they've known about these charges since 2000. The BC Nurses Union has been yelling about them, and they've ignored all of that. So again, the federal government has this role. They've chosen to abdicate the responsibility for that. I think it would be amiss if we didn't talk about refugee healthcare just quickly. So refugees in this country, if you are deemed from a safe country, which does not mean that you are safe, you are not to receive public health care, and so you can be turned away. You actually have to pay for your care. The Canadian Doctors for Refugee Healthcare and Canadian Lawyers for Refugees challenged this, and Justice McTavish had a ruling earlier this year. She called it cruel and unusual. Now we've heard that the Harper government is going to challenge that ruling, and they're going back to court. Pharmaceuticals, of course, is one of the biggest areas of privatization. We are the only industrialized country that has a universal healthcare system that does not include pharmaceuticals. We gave an award to Marc-André Gagnon for his amazing work on this. He has a new paper out that shows that if you were to have a national pharmacare program, not only could everybody access drugs, we'd save $11 billion. There's a paper at the back written by Julie White with the Congress of Union Retirees of Canada. I got it right here. Please grab it before you leave today. It's got a lot of really good information about pharmacare and why we need it. Certainly we're targeting the premiers. That's part of our fight back, and the MPs. We're holding the annual lobby, which I talked about yesterday, November 25th. We hope that you can come and talk to your MPs about the privatization that you're seeing happening in your province and your experience. We had a question earlier today about CETA, NAFTA, and trade agreements, and what their impact is. Certainly they have a huge impact on healthcare. Germany is probably getting the best fight right now, so we're watching what they're doing and echoing their calls. And we see Harper continue saying, it's a done deal and we're gonna sign it, yet we've held him off for 3 years already. Every year he announces that he's signing this thing, and every year we find out that they're not even close. So we continue to ask you to fight against those trade agreements, and to hold the government accountable for federal health, or for Medicare in this country. Thanks.
So I have a couple of questions, and I'd like to start with dealing with sort of the medical tourism aspect. And Doris, I read in the paper a whole argument supporting medical tourism by the doctor that heads that program, and what he was saying is, this is really good because it's bringing in a lot of money, and we can put that money into our health system. How do we address that?
So first of all, let's put the name to the doctor. It's Dr. Bob Bell, who started the program at University Health Network. He has a different song now because he's the deputy. And his answer today is, I'm not the CEO. What the Bob Bell problem is, and that will be in the meeting tomorrow with the minister, is that not only we will not accept a moratorium, we simply want a ban, and that means he needs to undo what he started. The argument that it brings money is a faulty argument. Even if it was true, it's a faulty argument. Let's start if it was true. If it was true, still will destroy Medicare because of CETA, and because of NAFTA, and because of Shaul and Ziliotis, and because of either human rights or trade agreements. We will need to allow patients from Canada to receive care for money. So even if they brought money, it will be faulty for Medicare, It will not be faulty for the US, two-tier. For us it will. But the case is that they're not bringing enough money. And Sunnybrook already said so. Sunnybrook basically said to make money we will need to scale this up significantly. And the minister also knows that they will not bring money. Also there is a physician, Dr. Lee, he lives in the US but he actually is Canadian. And he has done a huge number of studies of how many companies have opened and closed here in Canada because they don't make enough money. So if they make money, breaks Medicare anyways, they don't make money, so even more stupid to do it. The answer is no. The answer is there are many ways to respond to the issue that you presented, which is real, that the federal government is cutting the funding. The only piece I would add to your comment is that all the premiers of this country, with very little exception, didn't say nothing at the time. They never, and I spoke at the time with the minister directly, Minister Matthews, they never pushed the issue of a health accord because they didn't want strings attached. So there are many ways to overcome the challenge of funding. Enhancing scope of practice of all healthcare professionals is just but one of them.
Okay, thank you very much. Are you ready, Terry?
I don't know.
So, when you were speaking, you talked about the fight back and what BC Health Coalition was doing in terms of the private clinics, trying to raise public awareness. And I was astounded to hear that the government certainly wasn't really looking at all the emails that were being sent. You had 1,500. So what else are you going to be doing to be able to, really get the government to notice or take notice of the importance of dealing with the private clinics and making sure that it's no longer an issue?
Well, that's the question, isn't it?
That's right.
What can we do? Well, so when the case was postponed, we did send a letter to the government saying that what we expect to come out of these negotiations. And one of the big pieces that we're really going to push on is the monitoring and enforcement of the Medicare Act in BC, because this is where the whole system's falling down, because they're not actually looking and or doing anything about it. And so it really is public awareness. I mean, it really, like, who was it that said, somebody said that people don't go and talk to their local MPs and the governments don't know what's happening, nothing will happen. Well, that's sort of where we're at and what we're trying to do. And, I know everybody in this room is trying to, fight the same fight, but it's just really interesting because people will not believe that that anything could happen to our healthcare system. And so we sit around the table all the time thinking, how can we get the word out? How can we tell them this is it? You have to stand up now, it's gonna go away. And when you come up with the answer, just give us a call. Because, we're talking about going back to doing the grassroots stuff, kitchen table meetings in communities, how leafleting, how do we get the word out since we don't have the media? So.
Yeah, it is thank you very much, and certainly that's something that, we all struggle with. How do we get our message out? And the one-to-one contact is very important.
So I just want to take a very small exception about the media. On the issue of medical tourism, the media has been absolutely on board. We have been on the Global Mail, Toronto Star, National Post, you name it. And the media is on board, and stay tuned because the media is, in many senses, more on board than anybody else.
Thank you. Now if we could just get them to do that with private clinics. question for Natalie. Certainly the private clinics is the main focus right now one of the main focus for the Ontario Health Coalition. What are we going to be doing to get the information out, get more information, and raise that as a big issue, big public awareness campaigns? We're sort of talking about that.
Okay, so couple things. I mean, I think just because it is always difficult to get the mainstream media. On the other hand, we've done a fantastic job of doing it. I mean, in all your towns where you've done major campaigns on the private clinics, there has been tons and tons of media. We passed around those binders yesterday with hundreds and hundreds of media stories. But the thing is that it's not commensurate to, and I think what people are responding to is it's not commensurate to the kind of echo chamber message organizing that the Fraser Institute and the other side are doing. And so the Fraser Institute, by the way, has $10.6 million a year budget and has, for the last number of years, really focused a lot on trying to reduce public confidence in Medicare, and yet they still have not shaken the stalwart public support for public Medicare. You know, it's really quite amazing. And so we have the public on our side, but what they have succeeded in doing is convincing people that that public services and public systems are not sustainable. You know, that message all over the place, that as if spending is going up instead of the other way around. Linda's going to talk about that in a little bit. But they've been very effective at sort of dampening people's expectations, lowering their expectations. And on our side, I think we have to say, okay, when you see a newly aggressive assault on Medicare for all, as we're seeing in Ontario and across the country, the response isn't to sort of cave to the right. The response is to say, okay, we need to mount an opposition to that is commensurate to the threat. We need to get more assertive or aggressive ourselves. We don't need to say, oh, how do we, message things in a way that we don't offend anybody or blend into the beige background. It's so frustrating to see that happen all the time. People in Ontario don't like the idea of an Australian mining company owning our long-term care facilities. They don't like it. And it just goes against, our instinct for, what would provide good care. And so the main thing, I think, the main obligation that we have as activists and as organizers, and everyone in this room is to give people the tools with which to show their resistance. They're on our side. Our job is to mobilize that, is to give them ways to make it visible. At this point, visibility, I think, is key. So we've called the major protest for November the 21st. This cannot be 1,000 people at Queen's Park. It needs to be 10,000 people at Queen's Park to stop the private clinic. So we'll all work together. An advertising campaign leading from there right through to the budget, try to move them off of zeros for hospitals, but at the same time as we fight to maintain the public and nonprofit ownership of surgeries and diagnostics. And we should join with Doris in the fantastic campaign they're doing on medical tourism. It's all part of the same thing. It's the dismantling of the public community hospitals we know. And this is the fight, and we just have to do it. But on the other hand, too, we've always supported community care. And so we need to push for the original vision of actual community care. And that doesn't mean giant chain, nonprofit or for-profit company-owned home care that has nothing to do with the community and everything to do with winning government contracts. We need to fight for community care that encourages people to stay at home, provide supportive housing and services and so on. And we need to fight for real reform in home care that would create a public and non-profit home care system for Ontario.
Thank you. So as we move and looking at pushback, all right, this is sort of the title of our panel here. With regards to the Canada Health Coalition, we certainly mentioned the huge drop in transfer payments from 50% to 18%, putting a great deal of stress on all the hospitals and in the various provinces and territories. Also the whole question with the refugee health. What are we going to do? How do we push back?
Well,
Together.
so November 24th and 25th in Ottawa, there's a big lobby that we're doing. We do it every year, and so we certainly invite people to come up and meet with their MPs, but it doesn't end there. So it's really important to come to the Hill, get the training, meet with your MP, but what's probably even more impactful is when you meet with them in your own riding. And what's really exciting is that we've got a federal election coming up. So if there was ever a time to go and talk to your MP, it's now. And maybe not even your MP, but the other people who are going to be riding in the riding, and start telling them that you're concerned. Tell them the stories that you have, things that you've heard in your community, the privatization that you're seeing or that you're experiencing. Let them know those things. It's really, really important that we have stories. So when we talk about the media loves stories. They love hearing personal accounts of what's happening, and we need to collect those. So if you have those, you know people who have those, please share them, encourage others to share them. Share them with the Canadian Health Coalition, share them with the Ontario Health Coalition, share them with people in your community and your colleagues and your friends. Let them know what's happening, because we need to start raising the awareness among people. Then they need to start pushing their MPs and the other people who will be running in the riding. We need to make this a federal election issue. It's really important, and now's the time to do it because the election's coming soon.
Thank you very much. And, you know, the election is coming. Now's the time.